In this miscellaneous urology lecture, we're going to cover a lot of the stuff that you're going to see a lot in primary care that might relate to the urologic system. This is going to focus primarily on the guy, and we're going to talk about prostate and testicular issues. We're going to start off with BPH, which is the most common and most prevalent of all the diseases in this lecture. Benign prostatic hyperplasia. The pathology here is that the prostate enlarges and closes off urinary flow for the urethra. The urethra travels through the prostate. And unlike cancer, which grows on the back and it's firm and nodular, BPH starts to grow in the center here. And what happens is that over time, it continuously hypertrophies into the way of the urethra and eventually leads to obstruction. In order to have BPH, you got to be old, right? So the patient is going to be over the age of 50 years old, and they're going to have lower urinary tract symptoms. They're going to have hesitancy, dribbling, urgency, frequency. It might sound like a UTI, but they just don't empty their bladder all the time. And the more severe the symptoms, the more obvious it becomes. So when you see somebody who has hesitancy, frequency, dribbling, trouble getting started, trouble emptying their bladder, you might do a DRE, and they might give this to you on the exam. The digital rectal exam is going to show you a smooth, rubbery prostate. They're essentially telling you it's not firm and nodular, it's not cancer. So you hear these things, it's like, okay, well, you probably have BPH. The first time they have BPH, it's worth getting a urinalysis and a urine culture because often it's difficult to separate out someone who has a urinary tract infection from someone who has BPH. These are going to be negative, of course, in BPH. So you're saying, all right, old guy probably has prostate symptoms, so let's just treat him empirically. You do that with alpha blockers, things like tamsulosin, doxazosin, terazosin. Tamsulosin is the one that's most bladder specific and has the least orthostatic hypotension. But all this does essentially opens up the urethra to let the flow happen. The growth of the prostate is still happening, and it's happening under the direction of 5-DHT. So if you add on 5-alpha reductase inhibitors, like finasteride, what you do is undo the BPH part. So this isn't going to work right away, but over time it will undo the blockage. Tamsulosin helps them right now, finasteride helps them down the road. But eventually, if this fails, what you might end up doing is a TURP, a transurethral resection of the prostate. Generally not recommended if you can avoid it because it causes incontinence and erectile dysfunction. So if you can get away with medications, you should use that. But there's another time where you might jump to TURP, and that's someone who's got obstructive uropathy. If they have obstructive uropathy as a product of BPH, you're going to end up at TURP. But you want to relieve that obstruction, of course. You're going to see someone who has abdominal pain, distended bladder, elevated creatinine, and you put in a catheter. And you escalate as necessary from an in and out to an indwelling like a Foley, all the way to suprapubic cath. And if you can't get the prostate symptoms under control, you might have to do the resection to relieve the obstruction. Now you might be considered and you might be tempted. Say, well, I'm worried about this person's prostate, so maybe I should get a biopsy. No, never biopsy for BPH. All you're going to do is cause the morbidity associated with the procedure, and it doesn't serve any purpose. You biopsy for cancer. And you say, well, okay, it's the prostate, and I kind of want to make sure it's not cancer. I'll do something non-invasive, like a PSA. No, don't do a PSA. We don't screen for prostate cancer anymore with PSA, and we certainly don't want to get a PSA in the setting of BPH, because if they have the symptoms of BPH, you just treat them with medications, and you see what happens. If your concern is for prostate cancer and there's a reason for it other than they have lower urinary tract symptoms, you get the PSA. All right, that's BPH. Let's talk about erectile dysfunction. Erectile dysfunction is caused by one of two things. It's either psych or organic. And that is the crux of evaluating someone for erectile dysfunction. Erectile dysfunction is defined by the inability to achieve or maintain an erection. Now, there may be many reasons for this, including being stressed out at work or not liking your partner anymore, just as well as having your spinal cord severed and don't have any nerve connection to your penis. So you have to figure out which one it is. And to do that, you do nighttime tumescence. You take a roll of stamps or a piece of paper that's gently taped together and you put it on the man's penis. A normal guy has erections at night. So if they have erections, they'll break the roll or they'll undo the tape. If that happens, they do not have organic disease. So if they have trouble maintaining or achieving an erection with a partner, they either need a new partner or they need to get counseling. So if the nighttime tumescence test breaks, it's psych and they need counseling or a new partner. If it does not break, that means they cannot achieve the spontaneous erections at night. It's an organic disease. And when you get to organic, you've got a couple of options. You can use the phosphodiesterase inhibitors, sildenafil, tadalafil. Those are very popular right now. If those don't work, though, you can use things like pumps or straight up prosthesis. The substrate of the person is going to help dictate where you start. By the way, there's also injectable prostaglandins, but no one's going to do that. So if the person happens to have atherosclerosis, they're hypertensive, diabetic, fat smokers, you first control their medical disease. You get their diabetes under control, their hypertension under control, and they may regain erectile function. But that's the type of person that sildenafil and tadalafil were designed for. People who have poor flow to the penis, if you just help them out a little bit, they can get and achieve their erections. But if someone's had spinal trauma, or they've had radiation or a big surgery to their prostate, phosphodiesterase inhibitors may not work. You can try them, of course, it's the next step, but where you're going to go is prosthesis, because if they have a severed spinal cord, phosphodiesterase inhibitors aren't going to do anything. And of course, also remember, no nitrates with phosphodiesterase inhibitors causes an unsafe drop in blood pressure. The next two diseases we're going to talk about are often tested against each other. And it's weird because in real life their presentations are completely different. But I want you to hear the things you should look for in the vignette in order to separate the two. The first one is testicular torsion. Very much like ovarian torsion in OB, the testicle twists about its pedicle, compromising its own vascular supply. It strangulates the testicle, it's ischemic, and it's going to die. Very much in the same way as the ovarian torsion, testicular torsion is going to be a spontaneous scrotal pain, comes out of the blue, not doing anything, all of a sudden, bam, spontaneous pain. The thing you want to look for in the vignette, and I don't know why they use this as the primary differentiating step, but it is a horizontal lie and pain on elevation are indicative of testicular torsion. Sudden onset pain, horizontal lie, raising the testicle hurts a lot. The cremaster reflex may be absent. If you're thinking of testicular torsion, you want to get an ultrasound with Doppler, which shows no blood flow. This is a surgical emergency. You take them to the OR and you untwist the testicle. If the testicle pinks up, that is, the vascular supply is returned, it comes back to life, you leave it be. If it stays dark, gray, or husky, it has to be removed because it's dead. Regardless, you're going to do a bilateral orchopexy, even if you leave it in. Because this one did that, the other one could do that too. With orchopexy, you essentially just tack it down so neither of them can spin and neither of them can have this problem happen to it again. Now, of course, if you remove one, you tack down the other. This is compared often on the test to epididymitis. And epididymitis is an infection of the epididymis. In those less than 35 years old, it's an STD, gonorrhea, chlamydia. In those over 55 years old, it's E. coli, and there's a sort of gray zone in between. The patient is going to present with sudden onset spontaneous scrotal pain. And this time the testicle is going to be in a vertical lie. And there's relief of pain on elevation. Neither one of these are going to have urgency frequency dysuria. They're not going to have signs and symptoms of a UTI. There's not going to be bacteriuria. It's going to be based on the lie and what happens on elevation. If you see epididymitis, you want to make sure it's not torsion, so you're going to get an ultrasound with Doppler. That'll be negative. That is, there's good blood flow. And then you treat them with antibiotics. If they're less than 35, you're treating gonorrhea and chlamydia. So you use ceftriaxone and azithro. If they're over 55, you're treating E. coli. So you're going to use a fluoroquinolone like ciprofloxacin. In real life, it's very easy to tell these apart. There's crippling testicular pain. The testicle is acutely tender. The person is writhing around in agony, and there's no flow to the testicle. In epididymitis, it's like, hey, it hurts here, and then you squeeze their epididymis, and then they jump, and it hurts. Like, in real life, you don't have to do this stuff, but for the test, look for the horizontal lie, pain and elevation for testicular torsion, and vertical lie and relief on elevation for epididymitis. You're going to do a Doppler ultrasound on both, and then surgery is required for testicular torsion, but antibiotics are all that's needed for epididymitis. And it is okay to skip the ultrasound with Doppler if you know for sure this is epididymitis. Going along with the itis, we want to talk about prostatitis. And it's important here to separate out whether or not it is bacterial or inflammatory, because the treatments are going to be very different. Either way, there's inflammation of the prostate, but one is going to be infectious and the other inflammatory. The patient is going to be old. It's going to be an old dude who has pyelo, and they look sick. Urgency, frequency, dysuria, fevers, nausea, vomiting. It's pyelo in a guy, but there's no CVA tenderness and there are no casts in the urine. And when you do a digital rectal exam, it's exquisitely tender. So the same reaction you get from CVA tenderness and pyelo, you get from the digital rectal exam. Now, you never repeat the DRE. Every time you do a digital rectal exam in prostatitis, all you do is increase the chances of introducing bacteria into the bloodstream. So once you've diagnosed prostatitis, don't touch the prostate again. But what you do want to do is get a urinalysis and urine culture. Because what you want to know is if this is bacterial, you're going to use antibiotics. If it's not bacterial, it's inflammatory, and you're going to use NSAIDs. And lastly, we're going to close with nephrolithiasis. We have a whole lecture on it in medicine nephrology, but I want to highlight it for you because you do need to know about it for the surgery shelf. There are a bunch of kinds of kidney stones, the most common being calcium oxalate. And stones hurt because they're in a hollow viscus and there's peristalsis. So every time the peristaltic wave comes across the stone and the stone doesn't move, it hurts like crazy, and then the peristaltic wave passes. So what you're going to get is a colicky flank pain that radiates to the groin, often with hematuria. In fact, the first step is to get a urinalysis. If there's no hematuria, it's not a kidney stone. The best test for diagnosing kidney stones is a non-con CT of the abdomen. If you can't do a CT scan, like you're a pregnant female, get an ultrasound looking for hydro. But the CT scan is like an X-ray. It'll show the radio-opaque stones, and most stones are radio-opaque. You see the stone, you know how big it is, now you can treat it. It's a little more complicated than this, but this is how it works. If it's small, less than 0.5 centimeters, you're just going to give fluids and pain control. These things hurt like crazy, but if it's small, it's going to pass on its own. If it's a little bit bigger, 0.5 centimeters, then you're going to add on medical expulsion therapy. It's basically a calcium channel blocker to help the stone pass through a dilated ureter. And this is where it gets even more fishy because the sizing doesn't really work here so much. But if you're a sizable stone, 1.5 centimeters, then you can either do stenting or lithotripsy. Lithotripsy is where they have these ultrasonic waves that break up the stone into smaller pieces. If you're really, really big, you're going to have to do some more invasive procedures, which borderline on surgery. If they are septic and obstructed and have a stone, they're going to need a nephrostomy tube to drain and then figure it out later. What I want you to see here is colicky, abdominal pain, flank pain, radiates to groin, CT scan positive, fluids, and pain control. More on this in the medicine videos. All right, so in this lecture we hit on some of the highlights of the diseases you have to know a little bit about. BPH is going to be old guy with lower urinary tract symptoms. The first time, rule out an infection, and after that, treat with medical therapy. If it gets really bad, cut it out. For erectile dysfunction, a lot of your energy should go into finding out if it's organic or psychiatric. If it's psychiatric, get them the counseling they need. If it's organic, start with phosphodiesterase inhibitors and escalate into the surgery stuff. No nitrates, but phosphodiesterase inhibitors because of hypotension. Testicular torsion is going to be spontaneous pain, horizontal lie, elevation makes it feel better, definitely need the Doppler to show no flow, go to surgery. Epididymitis, spontaneous pain, vertical lie, elevation relieves the pain, ultrasound with Doppler is not necessary, treat with antibiotics. Prostatitis is going to be the old guy who looks like he has pyelo, but he has a very sensitive prostate. Give him antibiotics if it's bacterial, NSAIDs if it's not, and kidney stones is that colicky, flank pain, radiates to the groin with hematuria, get a CT scan, treat with fluids, and intervene surgically, either with cystoscopy or something more invasive for those really big stones. That's miscellaneous urology. Become a better doctor. Subscribe now to get access to our premium content.